Hi, my name is Marie Romagnano, founder of Healthcare Professionals for Divine Mercy. I'm so happy to present to you our educational conferences that integrate medicine, bioethics, and the spirituality of divine mercy in patient care for healthcare professionals. Because of their importance, even if you're not a medical professional, we invite you to join us. Today, I wish to summarize a very important and timely presentation given by Dr. Scott Bateman titled, Turning Off the Vent, Preparing the Family, Patient, and Staff. Dr. Scott Bateman, who is the Division Chief, Pediatric Critical Care at the University of Massachusetts Memorial Medical Center, discusses practical guidelines following church teaching and standard medical practice in deciding when to turn off the ventilator and outlines steps that should be taken along the way. A guide to decision-making is taken from the document prepared by the U.S. Conference of Catholic Bishops called Ethical and Religious Directives from the Catholic Healthcare Services. This highly informative document provides a roadmap in decision-making and states that the reflection on the innate dignity of human life in all its dimensions and on the purpose of medical care is indispensable in formulating a true moral judgment about the use of technology to prolong life. This is a core principle to follow. The deeper question is, are we saving life or postponing natural death? Withdrawal of life support does not mean withdrawal of care. We may limit life-sustaining efforts, but continue with comfort care and allow for a natural death to follow. There are over 50,000 pediatric deaths yearly, and over half occur in the first year of life, and most end-of-life issues occur in the hospital. Miracles happen, but may not be in the form the family prayed about. There may be the death of the patient, but through organ donation, many lives be saved. St. Pope John Paul II in 2004 stated that artificial nutrition, such as a G-tube feeding, and hydration, such as an IV, are considered ordinary, not extraordinary care. Terry Schiavo was stable and only needed her feeding tube replaced. This was denied. She died of starvation as she was denied basic food and hydration. With regards to life-sustaining treatments, they may be withheld or withdrawn and may be removed sequentially or simultaneously. Most deaths occur within 24 hours after cessation of these treatments. A few factors to consider when removing the vent include the following. Number 1, full awareness that there is less than 10% chance of survival outside of the ICU. Number 2, perception that the patient did not want extraordinary care to prolong life. Number 3, a high likelihood of poor neurological outcome. Number 4, use of vasopressors and ionotrope to maintain stability. Dr. Bateman offers sound principles regarding the ending of life. He offers insight on keeping the patient and family informed, allowing time for the information to be digested and understood, and of the necessity of keeping good records. Greatly valuable is his clinical criteria for brain death. I invite you to listen to Dr. Bateman's full presentation on a very timely subject for our society today, turning off the vent, preparing the family, patient, and staff from both the medical and Catholic perspective. Thank you.
Well, there's a reason why no one's talked about this, and I can tell you it's very, very difficult to talk about. I agreed to do this talk, and the more I thought about it, the harder it was to try to summarize and put into some sort of perspective. Who am I to talk about this? I am not a theologian. I'm not an ethicist. I have not written any books. And I am definitely no divine physician, that's for sure. But what I have done is I'm a pediatric ICU doctor. Been practicing in the ICU for over 15 years, taking care of critically ill children. I am a palliative care doctor. I am trained in one unit of clinical pastoral education, so I have done a lot of thinking about the faith in our ICU, and also am a convert to Catholicism, which has been what I've talked about in the past. I found this picture of the plug in the shape of a church, which I actually thought was great because the context of withdrawing the vent or pulling the plug tends to have a very bad connotation. And I do think that there's a way to talk about this and maintain my faith-based and also how to kind of think about it in our own Catholic faith. I'm going to be referring to a lot of people who are experts in this field, including the United States Catholic bishops. I'm going to draw a lot from their publication, The Ethical and Religious Directives for Catholic Healthcare Services, and try to pull together many of the kind of experts in the field on withdrawal of support or the ventilator. And I'm using the ventilator as the overarching theory of just taking away our life-sustaining treatment. So when Marie asked me to do this, I was kind of at a loss on how to format it. So actually, she gave me a list of 7 questions that I'm hoping to cover and hope to answer as best as I can. Some are a little bit longer and some are a little bit shorter, but I will do my best. So I wanted to kind of get into the mindset of why this is important. This is a little baby who is on the ventilator, and what you can't see very well here is these 2 major catheters, which are full of blood, are part of an ECMO machine, which is extracorporeal membranous oxygenation, which is heart-lung bypass machine, which is kind of the ultimate form of technology that we can offer at this point. In fact, this type of technology is actually what got me into critical care in the first place. There was a little boy whose name was Scott, who I took care of when I was a resident, who was on this machine for 3 weeks of very high intensity care, and to see his recovery and to know that he's now a high school senior. It's kind of showing my age here a little bit, but he's definitely survived, and I was all gung-ho about the use of what amazing things could be done with the science of technology. But at the same time, this technology is left us in some very tricky situations that have left us kind of having to decide when do we stop. And that's where I'm hoping to cover today. So this is the first quote I'm having from the Ethical and Religious Directives from the Catholic bishops. And it's something that I hope everyone can do, and that the reflection on the innate dignity of human life in all its dimensions and on the purpose of medical care is indispensable for formulating a true moral judgment about the use of technology to maintain life. And that is the core principle that everyone, hopefully, in this room and everyone can bring to their care settings to be able to have that reflection on what is in the best interest to maintain the dignity of that patient, because it's not always clear. I've seen medical technology like the little boy Scott I mentioned. It's done wonders, and we've saved millions of lives. The use of ventilators, the use of dialysis, the use of blood pressure medications, the use of ECMO even, has saved multiple lives, not only children, but also adults. But the reality is also that medical technology has allowed us to prolong the life of patients with fatal diseases, with organ failure or severe injuries, and thus postponing natural death. And that's where, when you get into this realm, you need to kind of really assess any and all forms of technology that you will be using. And I think that the ability to kind of think about what types of patients you might actually be thinking about. Now, I'm in pediatrics. I can tell you that we go the extra mile for our children. There's no doubt about it. Any child has the ability, such a long potential life ahead of them, that I think that we actually probably err on the side of doing more than you would imagine. And I think that it's even more so than in adults, where I think there's more of a sense of saying, is this appropriate in the long run? That being said, we do reach a point when patients have potentially cystic fibrosis, they have end-stage lung disease, they're not a candidate for lung transplant. There's absolutely nothing else we can do. The ventilator in that situation becomes a means of prolonging their inevitable death. The patient with a progressive neurologic disease that has left them more and more incapacitated, those patients have an ability to be supported by mechanical ventilation, so to speak, but they don't necessarily have any meaningful benefit for the underlying disease. Or the patient who is in a severe accident or severe traumatic car accident, who comes to us and the heart is actually able to be resuscitated, but the rest of the body really has suffered severe injury. And the ability to kind of put the context of what kind of support you're providing for that patient when we know that the underlying injury to the brain in particular is devastating is something that we constantly are needing to assess and really evaluate. I want to clarify that withdrawal support does not mean withdrawal of care, and that is a very key point when you're addressing any sort of topic in the withdrawal of care. And that the ability to kind of frame it in a different way, we like to use the term life-sustaining treatments or comfort care measures only. And the term that we're using a lot more these days to help people understand is we're not killing the patient, but we're allowing natural death. And I think that there's a very big distinction between those two. If you have someone with an underlying disease that will succumb regardless of what we do, and that our technology is not providing any sort of benefit. So I'm going to give you a small perspective on why pediatrics is affected by this. This is why I got interested in palliative care in the first place, is because even though deaths are relatively infrequent, 55,000 per year in the United States, a lot of them are in the first year of life. You can see what the common diseases are, congenital anomalies, cancer treatments, and unfortunately unintentional injuries still is on the list. And that most pediatric end-of-life care occurs in acute care hospitals, so that the ability to kind of be able to provide this type of care is important to anyone doing any sort of critical care. And that 2/3 of deaths in a PICU follow some form of withdrawal support. So it's happening enough that we have to be able to know how to do it and do it right. And this isn't just in pediatrics. This is a slide showing the percentage of patients who die in the hospital and the number of patients who die in the ICU based on their age. And the percentage in children is much higher. And then as you get older, the biggest block here is actually ICU. So there's a fair number, a good majority of, or not majority, but a fair number of patients who are dying in the hospital in the ICU. So the ability to kind of think about these topics is important. So the first question that Marie asked me was, how do you prepare the family beforehand with the medical status and the clinical information? I'm going to spend the most time on this topic, this question, because it is by far and away the most time-consuming and the most important for communication, conveying of information, an ability to kind of come to an agreement that is right for the patient, right for the family, and is what the belief of the care team is. So the President Commission in 1983, which was pulled together by Reagan at the time, came up with some directives on how to manage situations in the ICU or in any other setting where you're dealing with end of life. And there's a physician assessment, there's what the parents want to do, and how you should probably go about pursuing care from that point. So if the physician clearly says that it's beneficial, then there's no reason not to provide treatment. In fact, even if the parents prefer to forego treatment, there is a very clear directive here to provide treatment during review process. And I can tell you that the side of life is actually very upheld in the court of law in most across the country. So that if there's a healthcare team who feels like that there's something that is beneficial to a patient, you can go to court to try to maintain treatment. So that kind of fits into that. If the treatment is ambiguous or uncertain, and parents prefer to accept treatment, that is when you should continue to provide treatment. If the parents prefer to forego treatment and there's ambiguous or uncertain, then there's a directive to think about how to forego treatment. And again, if it gets even worse, where it's ambiguous, but then it's actually futile. Futility is a word that is thrown around a lot in the medical world as providing something that provides no benefit whatsoever in the mind of the people who are caring for them. And if the parents continue to prefer treatment, and this goes, and I'm going to be talking about parents and kids this whole time, but you can definitely have adults in here too, of the family, and I'm going to talk about advanced directives a little while, but that you should provide treatment in a futile situation, and there are provisions that you can excuse yourself if there's still an ongoing push for treatment. But if it's futile and the parents prefer to forego, that is, it's considered, this is a directive to allow you to forego treatment. So some categories that kind of help direct kind of the initial conversations are to broadly put into certain situations, like consider the unbearable situation. In the face of progressive, irreversible illness, further treatment is more than can be borne. What's the situation of that? That is the cancer patient who's had 2 bone marrow transplants, who now has interstitial lung disease, who may have thought that potentially they could have gotten better being on mechanical ventilation, but the overarching underlying diagnosis has gotten to the point where there's no hope for any further treatment options. And so that in that situation, using mechanical ventilation or even not starting in the first place, which I'll mention a little bit later, is on the table. The no-purpose situation may be able to survive with treatment, but with severe impairment that would be unreasonable to expect them to bear. And this is a very large gray area of opportunity for discussion and assessment of values and family interests and their spirituality and any other aspect that could be influencing their decision. How do you determine there's no purpose in what you're able to sustain with your life-sustaining therapies? Now, we're not talking about patients who don't need any form of medical assistance, is what we call it. We're talking about patients who are on the ventilator or on some sort of invasive therapy, dialysis or a heart assist device. And then brain death, which I'm going to mention a little bit later. I'm going to go in, because that's one of the other questions that Marie asked me. I will go into that a little further detail. So again, I'm going to go back to the ethical and religious directives from the Catholic bishops, United States Catholic bishops, that says, while every person is obligated to use ordinary means to preserve his or her health, no person shall be obliged to submit to a health care procedure that the person has judged with a free and informed conscience not to provide a reasonable hope of benefit without imposing excessive risks and burdens on the patient or excessive expense to the family or the community. So it's very clearly stated in the ethical directives that we substitute parent in that situation who feel like they're making the decision for their child, and being able to kind of discuss the risks and the benefits and the ongoing complications potentially related to ongoing medical support becomes a very interesting and contentious and heart-wrenching discussion many times. The excessive expense to family or community is hard to judge, but for instance, someone being on ECMO, which is that heart-lung bypass machine, how long do you stay on that knowing that there's no potential outcome that is beneficial or in any sort of reasonable outcome? And then our Directive 57 and 59 are also from the directives that say very clearly that a person may forego extraordinary or disproportionate means of preserving life. Disproportionate means are those that in the patient's judgment do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or the community. And then 59, Directive 59, the free and informed judgment made by a competent adult or their surrogate concerning the use or withdrawal of life-sustaining procedures should always be respected and normally complied with unless it is contrary to Catholic moral teaching. So that I wanted to just clarify a little bit that life-sustaining treatment, like I mentioned, can be withheld or withdrawn. In fact, a lot of what we found is many families have a much easier time withholding intubation or going on the mechanical ventilator than actually taking someone off. It's more, even though they're ethically the same as far as the ethical principles surrounding them, as far as the same directives apply to withholding or withdrawing care. There is, I think I've found that families find it much easier to say, if things get worse, we don't want to do this and we don't want to do that. And I think that has been a focus. A lot of our care in the ICU is trying to incorporate kind of some of these discussions before things get too far. You can remove life-sustaining therapies simultaneously or sequentially. There's a whole different, there's multiple different ways this can be done. And that most deaths will occur within 24 hours following withdrawal of life-sustaining treatment. So the timing of it and the ability to kind of be able to create an environment of dignity and hope in the setting of a death is actually one thing that we really do try to focus on. So I've kind of mentioned extraordinary, disproportionate, so I'm going to try to put some words to that. How do you define that? So cardiopulmonary resuscitation, or CPR, is also saved millions and millions of lives. There's no doubt about it. But in the setting of patients with progressive disease, actually doing CPR can be very damaging. You can break their ribs. You can create bloody secretions. You can, and if if someone's going to die regardless of whether you do CPR or not, and if you think about them going through CPR in the last moments of their life, we do try to think about the potential benefit of CPR before we get there, which is the whole rationale behind doing DNR, doing advanced care directives. So mechanical ventilation, again, I've cared for multiple patients who are on mechanical ventilator who I don't think is extraordinary because they're on for a short period of time. I have patients who are on the ventilator for their whole life, but I know that there are certain situations where being on a mechanical ventilator for the rest of whatever life they have left is not the type of medical assisted life that is probably what they would want or what the child deserves. And that's where what's causing the underlying reason to be on the mechanical ventilator is obviously important. Defibrillation or getting shocked, external pacemakers, medications, vasopressors or antiarrhythmics, circulatory assist devices. ECMO is the ultimate circulatory assist device, but there are things called left ventricular assist devices that are considered extraordinary for pretty much everyone agrees across the board. Now, Pope Pius the 12th actually was really kind of set the stage for this back in 1957, and he defined extraordinary as medicines, treatments, and operations which cannot be obtained or used without excessive expense, pain, or other inconvenience, or which, if used, would not offer a reasonable hope of benefit. And so a lot of the ethical directives and approaches have followed after this directive, or this, this quote and his explanation of what he considered extraordinary care. So extraordinary care, even the ones that I thought were very clear, there's clearly a lot of discussion about things that you don't necessarily think of extraordinary care. Now, as St. John Paul has made a very clear statement about artificial nutrition and hydration in 2004, saying that it is considered ordinary care and not extraordinary and should never be withdrawn, although there are morally acceptable reasons not to do artificial nutrition in the dying patient that I know that have been the topic of previous talks. Tracheostomy, same St. John Paul also had a tracheostomy, but that is a invasive device in someone's throat that many people find to be a form of invasiveness that is where a discussion should be drawn as far as what are we doing as far as prolonging this life. This dialysis, blood transfusions, IV antibiotics, even suctioning. Suctioning can be quite noxious to people. Chest tubes, surgical procedures. You wouldn't call any of these extraordinary. But there are situations where, again, when everything else has failed and you are in a point where you know that they have a fatal disease, you are, as a steward of their health care, we are obliged to really, again, go back to that original thing. What is the purpose of this medical intervention? What is it best for this, the dignity of this human? When studies have looked at factors that are important in parents or surrogates and then of life decision making, physician recommendations are number one. The diagnosis, expected neurologic recovery, and the degree of pain and suffering. All the things you would say, yeah, that makes sense. But it also highlights the fact that our job as physicians or as communicators have a very major impact on what the family is going to hear. And there's ability to kind of get confused, get lost in the details, and our ability to kind of talk about why we think something is futile, why we think something may not be for your child's major benefit. The diagnosis, being able to understand that diagnosis. The neurologic recovery, it's remarkable how often the ability to recover from injury, illness, disease affects your body so dramatically, but the brain and its effects can be the most predominant factor that's left after a period of time, because almost every other part of your body actually has amazing recoverability, but the brain is kind of a one-hit problem in that once you've lost and brain neurons have died, their recovery is very, very, very nil, and so that's where that becomes a fulcrum very frequently. Other factors influencing parents' decision, being able to elicit these are important. What is their previous experience with death? That has a major impact on what families want and have experienced. End-of-life decisions making for others. Their personal observation of their child's suffering, their perceptions of their child's will to survive, their need to protect and advocate for the child, family's financial resources. And I didn't put it on the list here, but actually thinking about this after this morning's talk, I wanted to just say belief in miracles. I believe in miracles too. In fact, I find many families believe in miracles. Even atheists believe in miracles at the time when someone has a very, very severe illness. The old saying, there's no atheists in foxholes. I can tell you there's very, very, very few atheists in a hospital room of a critically ill child. My take on miracles, in very short, brief statement, is that if a lot of times miracles, and I've seen miracles, but not the ones that you may be asking for. And I think that being able to kind of acknowledge we're hoping for a miracle too. If it's going to happen, it's going to happen despite what we do. And that many times there are miracles that you wouldn't necessarily have expected. I like to use the example of a girl who was in a tragic car accident, and she ended up being brain deaf and became was in our ICU for multiple days, and the family kept hoping and praying for a miracle. Despite that, she progressed to brain death, and then they were very hesitant to do organ donation, and we actually involved their chaplain in many conversations and family meetings, and the chaplain actually helped them come to a realization that this probably was a good thing. And that child was able to give 7 organs to 7 different people. And I've been in contact with this family since then, and they continually comment about the miracle that this organ donation has brought to them and to so many families in the area. And they have actually been in contact with multiple of the recipients. It's quite remarkable. So I don't want to take away miracles, and I think that what Brian was talking about before, is there a discordance between science and faith? I think you can keep your faith in the setting of providing good quality care, knowing that, like I said, if a miracle is going to happen, it's going to happen no matter what we do. And we can just do our best to try to provide what we feel is the right care. When you look at factors influencing clinicians' decision on the extent of life support to provide, you can see that this was a survey of physicians and nurses and what kind of factored into their thinking. And you can see that both nurses and physicians looked at the quality of life of the patient, the quality of life viewed by the family as very, very important. And then the ability to survive without life-sustaining therapy was also very high, and then it kind of went lower after that. The intact neurologic survival, living with a chronic disorder was much less, and then fear of litigation, thankfully, was not high on the list. And then the financial cost to society was low, and as far as factors influencing these decisions, but actually does have a lot of impact in kind of larger scale social media environments. But we also have to recognize that clinicians have attitudes and practices that they bring to the table too, and that they can vary. And I think that being able to kind of appreciate where everyone's coming from and what factors that might be influencing their decision. My father-in-law, who is actually a very devout Catholic, he said to me, "I want a Jewish doctor." And I said, "Why?" He goes, "Because they don't believe in heaven, and he'll probably work a little bit harder to keep me here." So he was sincere about it, and I think appreciating where the clinicians are coming from actually, I think, does have an impact on, and is something you want to be aware of, and allow that to be a part of your discussions. I often share, like I said, I believe in miracles. I believe that I said, and I'm hoping, always giving some sort of hope that maybe something will happen, but we need to kind of think about the big picture here too. So, this has also been looked at in the New England Journal of Medicine, factors influencing removal of the ventilator, and the physician assessment of having a less than 10% survival out of the ICU based on the severity of illness was definitely the number one factor leading to the discussions about withdrawing life-sustaining treatment. The perception that the patient did not want ICU care done was also a factor. High likelihood of a poor neurologic outcome, and the use of inotropes to support blood pressures, which was much less, but still was significantly a factor. So overall, what is our responsibility in the decision-making process? We need to make sure that we inform patient and family when end-of-life discussions need to be happening. And like I said, we're trying to actually do it earlier, and so that there's a possibility of analyzing therapies before they happen instead of just kind of moving straight through with everything we have if we have a truly fatal disease. And that we need to provide patients and families with adequate information about the therapeutic and diagnostic benefits of everything we do. Elicit questions and ascertain whether or not information and advice is understood, and ascertain the patient and family's personal values and goals of therapy. Allow time for information to be understood. This is I'm going to highlight in the next slide, but the ability to kind of hear what the physician is saying, understanding it, and be able to kind of come to some conclusions can be very, very difficult. And document orders and progress notes of what you've said. When you look at the time factor is highlighted in this slide, just looking at the consensus was obtained in a family meeting. After the first meeting, only 50% of the time, and then 97% of the time after the second meeting, which really highlights how time really does make a difference. Who was present at the meeting? I'm sorry to see chaplains at the bottom of the list, being only 10%. And I think that what we've really tried to do is incorporate every family's spiritual advisor in as many of these meetings as possible. It's been remarkable to me to see the influence of spiritual advisors in these family decisions. Because I think part of the reason why I accepted talking about this, because I feel like there's so much confusion and misconceptions about taking away support, and that it's counter to the belief in life and the dignity of each person. And I feel like a lot of times the spiritual advisors help to really kind of set the tone and help kind of be the mediator between the medical team and the family, because family clearly wants survival, wants their child to live. The family, I mean, the healthcare team does too, but we also are very aware of when things become harmful to the patient and clearly no benefit. And so being able to kind of navigate that with their spiritual advisor I've found to be very, very important, and I encourage that. So I'm hoping that number is much higher at our ICU. And I know it may not be in the meetings, but it's definitely in their involvement is very important. The three major principles of bioethics pertain to these, which is autonomy, making sure that there's self-determination and accept the likelihood that different persons may judge benefits differently, being able to kind of address the risks and benefits, understand what is a burden to the family, why that child with cancer can't really imagine being on a ventilator for the rest of their life. Being able to kind of allow that family to talk for that child, or if they're an adult, has there been anything that they've expressed, their wishes? Beneficence requires that only treatments that are in the child's best interest be pursued. And non-malevolence, which is to make sure you're not adding any harm, whether that's physical, social, or psychological, or spiritual. It definitely highlights for me, I never have to deal with this, because the parents are always the surrogate care providers, and very, very few children actually have expressed wishes about what their end-of-life care should be, but anyone who deals with adults knows how important advanced directives are, how important healthcare proxies are, and even informed consent from the rare patient who's alert and conscious and able to make a decision on their own. So please try to encourage that in your care settings. It makes a big difference. So that was a lot about the actual first question, because I think it's the hardest. It's the one that like I said, we spend the most time. Being able to kind of express what I feel in both as a medical person and as a human of what we're doing for this child. That child on ECMO who survived was spent a lot of time with very, very advanced therapy that I felt was beneficial, but I've also had patients on ECMO who at a certain point the recoverability became very, 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 very low, so that we really did have to start changing our discussions and being able to kind of be aware of when those discussions are, to have them in a faith-based way, to feel like you have trust between yourself and the family is vitally important. And us as care providers have an obligation to make sure that we are true to ourselves, we have our own moral compass in the right place. And, you know, it's hard because this topic is loaded with issues where you feel like the medical profession is counter to what families really want, that we're trying to kill patients and they want to keep them alive. And I do think that there are abuses of the system, but I think that if you can bring your own sense of morality and faith-based approach, you can actually be pulling the plug with that faith-based action and have it look like that cord in the shape of a heart, in the shape of a church. So the next question that Marie asked was, what is the clinical criteria for brain death or withdrawal of life support? So there's no criteria for withdrawal of life support, but there is criteria for brain death. And this is an area that has gotten a lot of press lately. And I don't know how many of you know who this is, but this is Julia McMath, who's the 12-year-old girl in Oakland who was pronounced brain dead after a tonsillectomy surgery that went awry. And it really highlighted the confusion of brain death. And I was actually looking at the DivineMercy.org website last night, and there was an article called "He Was Brain Dead, but Then We Prayed." And I clearly, because I read the article, it was the boy was definitely not brain dead, and I wanted to kind of clarify that brain death is a very strict clinical diagnosis that we do not take lightly, and is one that is been confirmed by both medicine and also is consistent with Catholic teaching, which I will show you in just a second. So what is brain death? It's defined as the irreversible cessation of all functions of the entire brain, including the brain stem. And that's so really the entire brain. So what we do is we look at the underlying basic functions of every single aspect of the brain that we can measure. And there are 3 clinical findings that must be present: cerebral unresponsiveness, absence of brainstem reflexes, and apnea, which is the ability to kind of take a breath, is one of the most basic aspects of our brainstem. And if you cannot actually initiate a breath, even with the appropriate stimulus, indicates that there's no activity there. So the criteria, there's a protocol that is accepted for almost every major medical center in the country that has very clear criteria on what is considered brain death. And I think what I've seen is brain death is used as too broadly. There's a lot of patients who have severe injury, but they don't necessarily meet the criteria, which is this, and I'm going to go through it. So you have to make sure you're not hypothermic, because hypothermia can alter a brain death test. You have to make sure you're not too hypoxic, so you have appropriate oxygen, you have good blood pressure, you have no other biochemical, your electrolytes aren't out of whack, you don't have any sedatives or anything that could be altering your mental status, neuromuscular blockade agents which would make you paralyzed medically, alcohol or any other sedating drug. Once you have that, then you do 2 clinical exams separated in time. It's 6 hours in adults. It is 48 hours if you're less than 2 months, and it's 12 hours if you're between 2 months and 18 years. And it actually is 24 hours for all of them if it's due to anoxic injury. So 2 specific exams that allow there to be consistency. If there's any change in between exams, they're not considered brain death, and that is a very important distinction. But if you fulfill all these criteria, and then what we do is we do motor response to stimuli, pupillary response, gag reflex, corneal reflex, oculocephalic, which is another basic reflex, cough, and then the last test is called the apnea test, where you actually, and this is an area that I actually like to have family present for to see, because it really hopefully drives home that there's no activity there that is underlying. And what you do is you put them on a ventilator, but you take away any breath. So they go through a period of about 10 minutes. And if the CO2 rises enough and they don't take a breath, that is considered a negative apnea test. And that is the final test of the 2 clinical exams. You can just do the 2 clinical exams, but you can also do ancillary tests, which are considered supportive, which is like doing an EEG. It has to be flatlined, or nuclear medicine, where they actually tag the red cells and see if there's any blood flow going to the brain. Transcranial Doppler looks also for blood flow in the brain. And what's actually become the gold standard of ancillary tests is the 4-vessel cerebral angiography, which is a CT scan of the brain done with contrast. And if your brain doesn't have any blood flow, then it's considered a negative test, and that confirms your clinical exam. And if you fulfill all these criteria, again, separated in time. Then at the end of the document, if you have checked these boxes, you actually declare someone dead by neurologic criteria. It's not just the media and that are confused about brain death. I actually was asked to testify in a case about 5 years ago of a child who was in our ICU in DCF custody or under state custody who met all the criteria for brain death, but the court wouldn't allow us to stop the ventilator, and I had to go to court to explain why he was brain dead, and I brought in my CT angiography just to show that there was no blood flow there, and after that meeting, we did stop the support. So the National Catholic Bioethics Center actually had a response to the Julia Jahi McMath case. And they wanted to clarify things because it actually was interesting to see how the faith community became prominent in the attaching onto whether this was right or wrong, or whether she was really dead or really not, when it was very clear from a medical standpoint that she had met criteria for brain death. So the Catholic Bioethics Center did come out with a statement that the determination of death by rigorous application of the neurologic criteria is considered legitimate by the Catholic Church, which accepts the findings of the science in such a determination. The Catholic Church does not believe there can be any opposition between faith and science, since both are gifts from God, the source of all truth. And I also think that they were following the lead of John Paul, St. John Paul. I just changed my slide yesterday from Pope John Paul. Even though he said it when he was Pope, I still should change it, right, to St. John Paul. Okay, just go. And what he said is that specifically talking about brain death, this consists in establishing, according to clearly defined parameters, which I just went through with you, commonly held by the international scientific community, the complete and irreversible cessation of all brain activity in the cerebrum, cerebellum, and the brainstem. This is then considered the sign that the individual organism has lost its integrative capacity. Here it can be said that the criteria for the ascertaining the fact of death, namely the complete and irreversible cessation of all brain activity, if rigorously applied, does not seem to conflict with the essential elements of a sound anthropology. So I think he's a worthy source, and I think that was helpful for people really. And he was actually addressing a group of physicians at the time, trying to educate them. The other key aspect of brain death is that if the criteria is applied appropriately, the aspect of organ donation becomes much more apparent. So over 90% of organ donors in this country are from brain dead patients. And so the ability to kind of accept brain death as a diagnosis and to allow that conversation to proceed to whether organ donation is possible or not becomes paramount, which is why we work very clearly to document exactly what has led to the brain death, because I want to make sure that it is done with a patient who has died. So Pope Benedict was a strong proponent of organ donation, said that the act of love, which is expressed with the gift of one's own vital organs, is a genuine testament of charity that knows how to look beyond death so that life always wins. And again, I go back to that case of the girl who gave 7 organs to 7 different people, and they actually are all doing well, and how much that has meant to so many people, and the act of charity that has that led to that. So the next question that Marie asked me, how do you prepare the family spiritually with formal pastoral care? Before we get to the family, I do say that the spiritual needs of the patient must be addressed. Being able to offer sacraments of penance if they are able to cooperate with that, or the sacrament of the sick is something we always try to strive to get patients who request that. But also the spiritual needs of the family and caregivers must also be addressed. There's a survey looking at the spiritual needs of bereaved parents of a child in the ICU. And their most prominent need was to maintaining a connection with their child before, during, and after their death. So being able to kind of foster that, and obviously their connection after death has a lot to do with their faith and their spirituality, and being able to kind of foster that. Parents maintain connections with their child's last hospitalization through death by physical presence, always having them there. And parents maintain connection after death, again, through memories, mementos, memorials, and altruistic acts. And then another survey looked at matters of spirituality at the end of life. What did the parents find most helpful? Their prayer, their faith, their access to and care from clergy, and their belief in the transcendent quality of the parent-child relationship. Again, that just highlights how important their spirituality is in dealing with what is every parent's worst nightmare, is dealing with this type of situation. Looking at whether it actually makes an impact, this was a study looking at whether families actually had some positive outcomes from having access to clergy, and it showed that there was a very strong association between satisfaction of spiritual care and their ICU experience, even if they survived, actually, and that the spiritual care provided by a pastor or spiritual advisor was involved, made a big difference too. So we always, our UMass is actually a little thin on the chaplaincy services, but we always try to encourage them to come in these situations. Clearly, it's needed. Other spiritual care of the families, I had seen this in Rome and the Pieta, looking at Mary, and it goes along with what was talked about this morning, thinking about her faith and her grace at the bedside of her dying child, and how beautiful it was, but also thinking about how much pain she is in, and being able to kind of be a minister to that pain, but also just seeing how her love for her child was remarkable. And we see that in the ICU. We see what parent love really is, and trying to kind of be, and it's a privilege to be present to that on multiple occasions. This is a real-life example of, I feel, a mother in a similar state of grace, dealing with her child who has a congenital anomaly that's not going to make it. So the next question, how do you interact with your staff, preparing them for this situation? So I actually have one of our PICU nurses here, so she can comment if she wants to. What I feel is the most important aspect of how to deal with this from a staff perspective is having a culture where you can balance both intensive care and palliative care. Intensive care, which is the ongoing fight against death to cure and to prolong life at all costs. The majority of our patients, this is our mantra, this is what we're doing. But we do have to be able to kind of balance times where palliative care is important, and that is a culture that has to be in the whole ICU. It has to be pervasive to be able to kind of know that this is happening at the same time. And a lot of times you can have patients next to each other that you have the totally different mindset on. But the palliative approach to promote physical, psychological, spiritual, and social comfort, and to promote the acceptance of death as an outcome. I would say the first point is something that we actually are trying to bring into the intensive care side too, because I think that's good medicine no matter how you look at it, but just becomes more apparent when you have a dying child. And palliative care as an approach focuses on the treatment and physical, emotional, social, and spiritual symptoms of children, the life-threatening conditions in their families. Like I said, can be provided concurrently, and the goal is to achieve the best quality of life for a child and their family. And having a team approach to this, having everybody on the ICU team aware of how this is going to play out and start planning. And we'll be talking about the space in just a minute. But everyone in the unit, this is kind of a list of different people who a dying process is going to involve and how it affects all of them differently, but to be able to kind of talk as a team as to what the expectations might be. Nursing, there's students who are training, both nursing students, medical students, respiratory therapist students. They all are there to learn from us, and it's our obligation to be good mentors to them. Physicians, the pharmacists involved with medications at the end of life, respiratory therapists who sometimes get lost in the whole process, but their role in kind of turning off the ventilator or withdrawing the ET tube is very emotional to them, and being able to kind of be aware that this is affecting them too. We're lucky we have very excellent social work, and child life is a part of our care in pediatrics, which should be in adult medicine, but isn't, which is a focusing on the child as and their aspect to be a human instead of a patient. Really helps set the tone for all of us. We also work very hard to create a sacred space, silencing alarms, preparing the patient as much as possible, turning off monitors, preparing the physical space, and focus on comfort, and have medications in hand, and speaking carefully and respectfully. I've had a couple different feedback from families. One is I had an aunt of a family member say, just the little thing of dimming the lights in our room made all the difference and created a sense of sacredness and a hushness to the situation that really was so appreciated, and how we created a more quiet environment for them. And the speak carefully and respectfully part is that because this is a very important part of every patient's family's life, that the words that we use and how we say them in the end of life at the sacred moment of death is seared into their brains, and they can actually recount exactly what people said at certain times. So being respectful of that and respectful of the patient, and also your team dynamics is important. So as much as you can rally your team ahead of time outside of the room, getting prepared. We also try to monitor the physical space, invite the family to the bedside, allow time for rituals, and have things like washcloth, oral suction, catheter, facial tissues, reassess frequently. Allowing time for rituals. Again, I've said there's no atheists in foxholes, and there's no atheists in a death room. I've been involved with multiple different types of faith rituals, whether it's Native American or Greek Orthodox, and the ability of a family kind of bond at that time is really beautiful to see. There was one, I mentioned the Greek Orthodox one because there's this little 8-year-old boy, and he was passing away, and the entire room was filled with about 30 people. And hospital rooms aren't that big. And they had this big cross, there was a silver cross, that they were passing around to everyone. They were singing in Greek, I think, and they were passing this around. Everyone's kissing it. And myself and the resident and the nurse were in this room just trying to witness this holy event to them, and it was truly remarkable. I've seen Pentecostal families just be singing and chanting the entire time that withdrawal support is happening, and a whole myriad of things. And I can tell you that being involved with the care of patients passing away was one of the initial niduses of my own conversion to Catholicism. Like I said, you just can't help but see people's faith and their sense of hope and love and belief in an afterlife just becomes very apparent. This is a family who got into the bed with their child who had progressive neuroblastoma. We're just continually praying during the whole event. It just felt like it was so beautiful. So the next question, which hopefully not to spend too much time on, but exactly what happens when the life support is withdrawn from a clinical standpoint. I don't want to get too gruesome or too, but I do want to just say a few things. One is that there's two ways to stop the ventilator. One is to just take it away. The other was to wean it, where you start taking the ventilator away slowly. It's called a terminal wean. And where you slowly wean the ventilator. You need to prepare the family for uncertainty, because the timing could be minutes, could be hours, could be days. And there are even patients who remarkably keep breathing and get transferred out to the floor. And so we never know. And that's sometimes, like I said, miracles do happen. And being able to kind of provide a situation where bedside love and support can be fostered. Touch, holding a hand, talking to patients, and sharing stories. Also, this is a little boy with a congenital heart disease who had been through multiple surgeries and was now inoperable. And the family actually came together and invited their older sibling to come. And again, it's just a very poignant picture of how a family can come together and bond in that situation. Also need to prepare the family in knowing that there is what these are different types of breathing patterns that can occur, that you can have involuntary movements and reflexes. There's actually a thing called a Lazarus reaction, where a patient in some sort of muscle reaction, they actually can sit bolt upright out of bed, eyes open, and then they fall back down. And it's like this almost like release of potassium or calcium in their muscles, and it causes this reaction. And obviously, it can be quite troubling to watch. So trying to prepare families for that. It's very clear that providing analgesia and sedation when withdrawing life-sustaining treatment is accepted, and that we usually go up on the dose to some degree, and that even with going up on the dose, there's really no true relationship of going up on the morphine, which is our mainstay drug, and the time of death after the ventilator. They're mostly dying from whatever they were on the ventilator for in the first place. There is an ethical principle called the principle of double effect, which says that clinicians can give sedatives and analgesics to dying children to relieve suffering, and these medications may result in the hastening of death. However, the intention is to relieve the child's pain and suffering and not to cause death. I'm not in any way advocating any form of euthanasia. This is a way of using morphine, which has shown not to change the degree of timing of death after coming off the ventilator, but to really focus on suffering, on air hunger, on pain that could be accompanying taking away this medical support. I think there's two more questions. What is the care of the family and the child that has just died? what is this? This is the card that we post on the door of a patient who's just passed in our ICU. This is a outward sign to everyone in the ICU that there's something major going on in that room. Please be respectful. Please be aware that there's going to be tears. There's going to be a lot of family members in and out. And just creating just that one little piece of paper actually on the door has made a tremendous impact on how respectful people are around this situation. The ability to kind of allow families the time to be at the bedside even after death is something we also take very seriously, and our nurse who's responsible for that child will stay with them as long as they are needed, as long as the family's there. We do offer some bereavement support. We have memory boxes that are created. We allow them to do handprints, locks of hair. We haven't started this yet, but I saw it. It's a little, I've seen another institution print out an EKG strip of their patients before they died and roll it up and put it in a little bottle and give it to the families. I actually thought that was a really nice thing. We have a bereavement support group for our ICU that does provide some follow-up and try to help address whether patients need any sort of grief support. Sibling support is something we also have as a priority. I think this is, we have a child life specialist who really focuses on this. We have grief counseling available, and we have an annual remembrance service at our hospital for all the children who have passed away in the past year or even the past 5 years to come and celebrate their child's life. We also have to be thinking about tissue donation. Even if they're not an organ donor, we need to ask about tissue donation. We have to ask, legally about if they request an autopsy. But we also have to be culturally sensitive about the care of the body. There are different faiths that have different requirements about the care of the body that I won't go into, but are something that we should be aware of. We also help with funeral home connections. And then the last question is, excuse me, how do you care for the healthcare professional who has just lost their beloved patient? I think that is a whole other talk in and of itself. It is something that we are very aware of in our ICU. We do a wrap-up rounds, which is a multidisciplinary meeting within 48 hours of every single death in our ICU, where we have a facilitated discussion focused on the end-of-life care that we provided and the staff health. And I think that actually coming together after a death and sharing our stresses, sharing what has transpired, and that this was a major event in our lives too, has really allowed not only some healing to occur, but also our ability to kind of care for the next patient as a team, as a unified unit. So I hope I was able to answer the questions in a way that was satisfactory to everyone. I recognized how difficult this was as soon as I started putting it together. My wife was like, "How can you talk about this?" And I was like, "I don't know. I do know that it's very heart-wrenching, but something that Father Calloway said earlier, he said that the people that fall down the most need the most kisses, and it just made me think about the families who lose a child, I feel, have fallen the hardest because of dealing with something that no one should ever have to deal with, and they deserve all we can give to them, and it's our honor and privilege to be able to do that for them. So I'm going to end with two final quotes from the Catholic bishops. One is that above all, as a witness to its faith, the Catholic healthcare institution or its providers, or lay providers not in the Catholic, will be a community of respect, love, and support to patients and residents and their families as they face the reality of death. And then finally, that we must bear witness to the truth that those who are in Christ, suffering and death are the birth pangs of a new creation, and being able to appreciate that there is someplace way better than this here, but that we do respect life and what we can offer them here, but if they're going to be in heaven, that we can at least provide them with an exit from this life that is dignified and caring and loving. So thank you.